I am so excited to bring you these two podcast episodes with me and Dr. Angela Wright. Two episodes because we talked for so long, because we are both so wordy and verbose that the whole conversation went on for an hour 15. So I've decided to divide it into two, which actually works perfectly because you're going to love both these episodes if you are a woman, if you have a vulva, if you're somebody neurodivergent, if you're somebody with various chronic health conditions that maybe you think might be related to your neurodivergence, usually it is, and you're somebody hormonally sensitive. Maybe you have reacted really badly to hormonal contraception or HRT, like menopause medication. This is the first part. So this episode that you're watching, listening to now is about being hormonally sensitive. We also both talk a lot about our own personal medical histories and experience with the medical system. And I think you're going to find both episodes super helpful and affirming, and I hope maybe they heal something inside you as well. If you're used to being gaslit and fobbed off by the medical system, and again, I'm somebody who's generally very pro the medical system. I am pro Western medicine in many ways, but also we know that there is so little research into women's health conditions, female health, reproductive health, menstrual health, also chronic health conditions, neurodivergence. And so many of us fall under the radar and get, I don't know, treated really badly, given multiple different diagnoses. I really hope you find this episode helpful, especially coming from a medical professional who also lives it herself. Enjoy this episode, and the next episode we'll be talking about trauma-informed medical care, especially pelvic care. So enjoy. Hello, I've got the giggles as we're starting recording. Well, because I'm with wonderful Dr. Angela Wright, and we are both two very chaotically brained people. So it's an absolute miracle we started recording now. And I was just saying before I started recording, I'm going to try not to gesticulate too wildly and knock things because I found there's an issue with my recording. Anyway, welcome to the Naked and Unashamed Live podcast with moi, Lucy Rowett. And I'm so delighted to be joined by an amazing colleague, peer, maybe friend or not.
Friend. I think friend is a word.
Yeah, Dr. Angela Wright. And it's really cool because we've been following each other on socials for a while now, and we finally met in February this year at the European Society of Sexual Medicine Congress. She came to Vienna. She saw the lovely city. So before we properly start, I really would love you to introduce yourself, Angela. Tell everyone who you are and what you do, because I think you're marvellous.
I think you've done that already. I'm chaotically brained is what I am. I am from the UK. I'm a doctor. I'm a clinical sexologist, so psychosex therapy trained, but also sexual medicine trained with the ESSM. I like training. I've done menopause training. I'm about to embark on some new trauma training today. I like to learn lots, and I work in different settings. I work in the NHS, I work privately, and I do voluntary work.
Yeah,
I think that's me in a nutshell-ish.
Is in a nutshell, and I think you're marvelous because I'm always recommending you to people because you are not just a medical doctor, but you are a trauma-informed medical doctor and a sexologist. And what I wanted us to talk about today on this podcast, and also soft launch what we are hopefully going to be collaborating on, is slightly two different tracks. One of them is trauma-informed medical care, especially trauma-informed medical exams, but also hormonal sensitivity. And by hormonal sensitivity, that's especially for women and vulva havers with things like PMDD, with ADHD, or going through the menopause where you are hormonally sensitive and it's really messing you up, because these are two things that you know a lot about and are very knowledgeable about. And there's a lot that I want to ask you that I think would be of great benefit to my audience, to my listeners, to my watchers, because there's so much that needs to be talked about, to be debunked, all sorts of things. So are you ready?
Yeah, I am.
Dive into it. And as always, whenever I do interviews, I've got a list of questions and notes, so I don't go wildly off topic, but we probably will go wildly off topic.
I think with us it's possible.
It's very, very possible. So I'll say up front that I'm going to put all of Angela's links in the show notes, so do book in with her if you feel that you need to. If you feel that your GP is not listening to you, or your menopause specialist is not listening to you or taking you seriously, I highly recommend booking in with Dr. Angela and her clinic. So you talk a lot about, and you specialize in hormonally sensitive patients. What does that mean? Like, how does that show up?
I'm still trying to get my head around, what it is that makes somebody prone to it. Because I have this sense that there are a number of overlaps and kind of phenotypes that make you more prone to this. We know that there is a group of premenstrual disorders. It's thought of as an umbrella term that probably includes a lot of individual, different, specific types of sensitivity to your hormones. So the kind of things that people know about already would be premenstrual syndrome or premenstrual dysphoric disorder, which is in the DSM-5. It's a psychiatric diagnosis. It's kind of it's a more severe version of PMS, but it has lots of other features to it. But there's also individuals that have that sensitivity often also experience other issues. So if you go onto a contraceptive pill, you might have a significant mood reaction to it. Or if you become pregnant or postnatally, you might have problems with your mood in relation to the changes in your hormones. And we see loads of it in perimenopause and menopause because it's a really big physiological shift. So there's lots of different ways and types and individual triggers for people, but we see more of it in neurodivergent individuals. There's overlaps with trauma. You see quite a lot of autonomic dysfunction, so unexplained body stuff like dizziness and migraine and IBS. It kind of clusters and there's not much known about it.
And it's interesting because this is something very personal to me as well, in that I describe myself as having wonky brain, wonky body, or I describe myself as having a body that loudly protests about lots of things. I'm ADHD diagnosed, highly suspected autistic as well. And I also have a long history of chronic health conditions like ME/CFS, IBS. There's probably other diagnoses I could add to that list that I'm not sure I want to go down yet. And I'm always referencing someone called Dr. Jessica Eccles because she is a researcher under researching the overlap between hypermobility spectrum disorders or autonomic stuff and neurodivergence.
Yeah.
And now I'm going off topic here, what made you start getting interested in this in the first place?
I think, just like you, this is something that I have some lived experience of. I don't have any diagnosis of neurodivergence, though most of my colleagues, when they meet me, assume that I'm ADHD diagnosed. They just kind of assume it's there. And my family has got autism diagnoses running through it. So there's a reasonable likelihood that I've got some quirks of my own. I'm hormone sensitive. I, trained as a doctor, worked in women's health for years, didn't have a good grasp of it. And it was only when I was doing my menopause training and sitting in a clinic that dealt with PMDD and coming to sort of the middle of my 30s where things were starting to spin off a bit for me in terms of my own mood regulation and how I was feeling very different at different ends of the month. And so the penny dropped a bit with me. And then I just kept seeing the patterning over and over again in patients. The more I did the specialist work, the more I attracted, I think, clients who were struggling with mood issues and so on as part of what was going on. And the more you just saw the same features in the history again and again and again. And loads of the women didn't have a diagnosis of autism or ADHD, but they had children who were going through that diagnostic process, or it was within the family. And we know that there's genetic and familial linkage with it. And so I suppose that's kind of, like a lot of us, you're kind of driven by the help you didn't get yourself, aren't you? Sometimes I think in terms of what pushes you forwards. And I'm always very aware that if I wasn't a doctor and if I wasn't party to this knowledge, I probably would have accumulated quite a lot of diagnoses myself at times interacting with the health service. And I just have a big question mark in my head as to whether we're getting this right. I think we've talked about this before. I think we're accidentally, doing a fair bit of damage because the models that we're trained in don't bring this stuff to the fore. You just talked about the overlap between neurodivergence and hypermobility. which is well known, and there's overlap there to CFS diagnoses, and often anxiety is put in with that, but I'm not sure it really fits there. I think that's slightly different. And we have overlaps that are recognised in autistic girls, for example, that there's much more likelihood of hormone sensitivity. So you can see how you'd hop from one to another, and you can see how you could end up with unexplained dizziness, unexplained joint pains. Nobody quite knows why you have this pattern of fainting or pain. And there's probably an underlying thing that pulls it all together, but it's just really poorly recognised.
I think, from my own lived experience of, I'm going to say the chronic illness community, but I'm not. I'm careful. I'm very careful what communities I engage with. I'm very much focused on recovery focused communities, but also I'm in all neurodivergent spaces. And we know that there's just not a lot of research, first of all, into neurodivergence in general. There's very little research into any kind of chronic conditions. There's very little research into women's health, into hormonal health. So it makes complete sense that for women and vulva havers with A, neurodivergence, B, bodies that like to protest loudly, C, hormonal fuckery going on, it makes complete sense that all of us are flying under the radar. And, I've got my formal diagnosis is ME/CFS. I know I'm hypermobile. I probably almost certainly have a form of Ehlers-Danlos syndrome. I just have not had the desire or capacity to go through a full diagnostic process for that.
I probably will. I went down, I had a rheumatology appointment. It was interesting. I was diagnosed with hypermobility, same picture that you're describing. I was repeatedly asked if I had anxiety in that appointment. And I repeatedly said, actually, no, I don't have any existing mental health diagnoses. I didn't recognise certainly any of that in myself. And I received my letter and it was there in my list of diagnoses. And I thought, you've just assumed that I have this as part of my picture. So there was that sort of, okay, this is how you accumulate labels that don't necessarily fit you. And again, my theory with it is that there's an increased internal awareness that we know is there. There's that interoceptive awareness, that internal state, internal change awareness that's there as part of that difficulty filtering out sensory stimulus that you have with neurodivergence. And of course, what is IBS? Often we're told that that's because you're just aware of the normal movement of your bowel, but you feel that as something that's uncomfortable or distressing. There's lots of theories about functional medical conditions, which is that your body's working normally, but for some reason it's bothering you. For some reason it's painful or distracting or just uncomfortable. And so I have this feeling that actually, it's for some of us, it's like there's a couple of layers missing and you're just super aware of internal state and external environment, super affected by stressors and potentially traumas, because we see trauma overlap in this group as well.
I think it's interesting because, I know this could definitely describe me in many ways. And again, I am in no way trying to diagnose anybody. I'm not qualified to. But from my own lived experience, I think I was talking to someone even the other day, even though I just did a podcast episode on embracing your sensitivity and your big needs, I still go through cycles where I try and convince myself I'm not a highly sensitive person, that my nervous system is not highly sensitive. I'm fine. I'm normal.
Yeah.
And then, something happens where my nervous system, my body will be screaming at me and I've got to take care of that. And I can definitely resonate with being hyper aware, hyper feeling everything.
Yeah.
And I talk a lot about the nervous system because understanding polyvagal theory, it has criticisms of that, which I understand, but it's been very helpful to me. And in my very uninformed layman's terms, I just wonder if it's just a nervous system that is highly, highly sensitized in many different ways, and we live in a world that doesn't support that.
Yeah, and we don't think of it enough in that way. And I don't really think increasingly, the more I train and the more I sort of train in those two modalities, so there's the sort of body-based medical side of things and then looking at it more from a psychological perspective, the more I think that divide is just so unhelpful, because you just can't pick one out specifically from the other, especially when you look at hormones. So sex hormones have direct impact on brain chemistry. So, the presence of estrogen potentiates the function of dopamine and serotonin. So the way we feel it because of chemicals going through our body. It's a physical change that creates a lot of feeling and emotion. So I just don't think it's possible to unpick one from the other. I think we are integrated beings interacting with our environment and the things that happen to us. And the only context that makes sense to me is to truly sort of go, okay, biopsychosocial, stick you in your specific context and work from there.
This is my model of how I work, but also my model of how I live. Like, I still remember, one of my friends, mentors, Tamu Thomas, saying there's no such thing as mental health and physical health. It's all health. It's all interlinked, which I really resonate with. And hang on, my brain is now going off into two tangents here.
Fireworks.
Yeah, it's more I just think there's a lot of value in neurodivergent women listening to this, really sensitive people listening to this, and I think it's also incredibly healing and refreshing to hear this from a medical professional, because so many of us have just experienced so much fobbing off from the medical system. And, I was saying to my husband a while back, is that, I think I said it to you as well, I go into a lot of medical appointments knowing in advance that it's going to be an uphill battle, that I'm going to have to convince, I'm going to have to state things in a certain way, that I know that if I want an outcome, I'm going to have to say things a certain way. Like, I take a medication called famotidine, which is an H2 blocker, and I was put on it, I think, quite a few years ago, because I get acid reflux, which is partly a side effect of the antidepressants I take. Anyway, during my first pregnancy, which was ectopic, I was changed to omeprazole, which is a stomach liner. And then I learned through various communities I'm in that H2 blockers are really good for lots of things, including PMS, including body stuff. And so I had to go back to my house arts, to my GP, but I knew I couldn't tell him that I want to go back on famotidine because it's going to help with PMS and it's going to help possibly with my chronic fatigue. I had to tell a fib and say that my acid reflux has gotten worse. Can I please go back on the famotidine? Because I knew that it would not compute for him. And that's just one very benign example of having to tell a white lie or having to slightly fib in order to get the result. And it's interesting. I've been on famotidine for about 2 months. I feel really good.
It's amazing, isn't it, that sort of need? And I think as an outlier, you feel that a lot anyway, to reshape yourself to fit the system that you're in. And it's difficult as a medic because I've got this emergent sense of where the problems were in my own training and where it left me inadequate. And what you see in, one of the reasons I'm starting to do some somatic training today, just for different approaches to use with my patients, is because that skill set is just not part of the way that doctors approach things. So we have a framework. It's a very Western medical framework. It's evidence-based, which is really important. But getting the evidence is really complicated. You only get evidence on questions that you choose to ask and areas that you choose to study. It's only as good as how well you design the study. And studies are difficult to design and get funded. So this idea that we have all the answers to everything because we've got the evidence base is one that I think is inherently flawed. And it is because when you treat patients, you get so far and then you're limited and you can't really work out how to make the change that you need to make. And that was the missing link, or the beginning of the missing link that I got when I started doing the psychosex training, was doing my own therapeutic work that you have to do, which was giving me a better self-awareness of the impact of lived experience and upbringing and family of origin and all that kind of stuff on myself. But in parallel, I was learning these skills that I hadn't had to learn to be a doctor because we just don't do work in that way. And realizing just how limited, our toolbox is. And because we're limited and because we feel crap if we say we don't know something, and we're not encouraged to say, here's my shortcoming, here's my blindness, I don't know about this, because we're taught that nobody will want to work with us if we say, I don't know. There's a lot of making it up and conflating and, I haven't heard of that, therefore it must be you that's presenting something that's crap, not a gap in me. So all of it, if I could reinvent all of it, I would actually want to say, doctors need to be given a different role, which is as knowledgeable fact finders, not people that have all the information in the first place, but somebody that you go to kind of walk with you to figure it out.
And that's interesting because I have another colleague, I guess, acquaintance, Dr. Asha Lamy, and they, again, were saying that it's difficult because they are a GP, a medical doctor, and yet they talked also about how the medical system is basically trained that you are the guru. And it reminds me of a lot of, it's very old school. We were having chats about this in Vienna, the difficulties in this I say institution, and there's a second segue we're going to go on to in terms of trauma-informed medical care, but I want to stay on hormones for a bit. But it definitely, so when I saw a psychiatrist here in Vienna, because it's a different medical system here, and I can just book in directly, which is great, because I wanted to explore going on ADHD medication. I decided not to, but I just wanted to see how easy the system was here, because in the UK it's just so difficult. And because I had my UK diagnosis, anyway, so he had to formally diagnose me again just for the Austrian system. But it wasn't long. And first of all, I just had to fill out these questionnaires, which were, in my mind, really primitive, because I was saying to him, yes, but this doesn't apply because I have all these coping strategies.
You'll be masking by now, exactly.
I know, and I didn't feel, and then I can't remember, there's certain names for these questionnaires, like they have codes on them, and I've filled these out multiple times, and I just felt they were really fucking primitive.
Yeah.
And also, like, well, technically I wouldn't score here because I have these strategies in place. So if I didn't have these strategies in place, then I'd score higher. Anyway, but then he was also asking about therapies that I'd done, and giving him a whole list. But on one of the forms, I mean, this is a very Austrian system. He'd never heard of somatic therapy, which is really interesting for a psychiatrist. Never heard of somatic therapy. But also because the Austrian system, they could only put down as official therapies things like CBT, psychodynamic psychotherapy, maybe Gestalt or something like that. I couldn't put on the form all the other stuff I'd had that I'd actually found more helpful, because in the Austrian system, it didn't count as therapy. And, I got my official Austrian ADHD diagnosis as well, confirmed it, and I was prescribed medication. I decided not to go on it because, for now. But I just left that feeling quite confused and quite baffled, really.
And I don't know what the answer is, because if you take evidence away, so those questionnaires are validated questionnaires, and they've been designed so that you can consistently prove that if you ask people those questions, that you're going to pick up reliably a number of people that have got the diagnosis, and they kind of accept you're going to miss some. And I think we know that they're really reductive. But the rigor that's required for an evidence base in medicine is kind of essential, and I like it, and I'm not trying to criticize it. But I think it's closed minds. I think it's made us think we have the answers to everything, the rule book for everything. And it does make it difficult to sort of take a broader approach. But I mean, particularly with neurodivergence, because most of the original diagnoses were young boys. They were one presentation of this. And, I was always taught when I was younger about the sort of lack of theory of mind, and, the empathy being difficult for autistic individuals. And in my experience of people with autism is the complete opposite. It's a hyper empathy, a hyper sort of feeling. And yet we just have this one model, this one image that we're working to. I don't know what the answer is to it. I kind of work in the system, and a lot of it I think is very important that we have. And particularly in areas where there are acute health issues and we have clear, safer outcomes like cancer and, emergency care and all that kind of stuff. Absolutely. But in these kind of more biopsychosocial diagnoses, I think it's quite inadequate, the approach that we take. And
Yeah.
and then if you do something that's a bit different, you're at risk of your colleagues thinking you're a bit weird or doing something that's a bit dodgy. And you've got to tread that path really carefully. I think I find that as a professional, how do I tread that
I
and
can really
keep the
feel
respect
that.
of colleagues, and but also go with my gut and with my own experience, but also what I see in the clinic room.
Yeah, I can really feel that. That is a very difficult path that you're treading,
Yeah.
trying to merge both worlds, and it's not a clean cut balance.
No.
Something I wanted to ask, because I think it's important, because this is going back to hormone sensitivity and especially working with menopause. How do you work differently with hormonally sensitive menopausal people as opposed to maybe another GP would?
I think you just know that it's there. The possibility of it is there. So when I sit down and do a history, talk to somebody about what's going on, I've learned to specifically ask them about previous experiences of mood shift at reproductive moments of reproductive shift, if that makes any sense. So I will say, what were you like when you were in your adolescent years? What's it been like when you've gone under contraception? I'll be specific about what types of contraception were acceptable and which ones created a negative reaction, because it really can be, I can't tolerate norethistérone, but I can tolerate levonorgestrel. They're two different types of synthetic progestin, but you can be that specific as to what you can tolerate. I'll ask them about pregnancy. I'll ask them about family history. Are there any other females or female-bodied individuals in the family who have had mood shift difficulties, psychosis post-pregnancy? Again, in my own family, it's not my mum's side, it's my dad's side, where his mum was on tranquilizers from menopause. Her sister was institutionalized because there was possibly bipolar, but probably there was something hormonal. It follows through family. So I ask the question, and then if you know that it's there, HRT, if you have a uterus, you have the estrogen, but you also have the progestin component, and you've got to use some skill in choosing the right progestin, getting the dose right, getting the route right, being alert. Because even with the best will in the world, you make the recipe and then you put it in the oven and you have to sit back and see what happens.
Yeah.
So a big part of my care is it's iterative. You can contact me if something's changing. And most of us have had such negative previous experiences on the back of hormones that there's a very genuine trauma attached to it. So there's a hypervigilance in the individual who's starting hormonal therapy. And when they spot any wobble, any change, there's often panic, particularly because many have got ADHD or, tendencies to act on impulse. So lots of people will stop, start, drop, change, give
That makes
up.
complete sense to me. Yeah, that
So you
makes
have to
complete sense.
handhold, provide that stable containment, if you like, of saying, just let me know what's happening. If you think you need to stop, I will listen to you because you know you, but I will give you my view on whether or not I think this might get better. And it's really difficult to do. I can see why lots of people don't want to do it because we don't have enough guiding science. It's not easy. The people who come in have had a lifetime of not being listened to and are, cautious of the whole process. So a lot of it's about gaining trust.
Yeah, that makes complete sense to me. And it, as you talk about hyper awareness or something, I could definitely go down that
Vigilance.
path.
Yeah.
That's the one, hypervigilance, because I know I've definitely felt that, because my I feel like my body, my internal state shifts every day.
Yeah.
If I'm trying a different supplement, if I'm trying a different medication, and I definitely resonate with that. Okay, my body's doing something weird. What's going on? Why am I feeling? Is it because I took this? Is it because I didn't take that? Is it
Yeah.
because of this? And you can drive yourself nuts. You really can.
And there's something in that. So, I often, when I describe trauma to colleagues who aren't trauma informed or haven't been given any trauma training, I often use the definition of it's when you feel unsafe and your resources are overwhelmed, that kind of, and you think, well, that's the experience of living in these bodies. Actually, a lot of the time is, how am I going to turn up today? Am I going to be able to cope with how my body feels? And is anyone going to listen to me and believe my experience? Because it's not everybody's experience. So I think there's an inherent trauma in living in a body that's behaving differently to other people's and trying to get help with
Oh,
that.
absolutely. My this is why, you know, somatic work and embodiment work has been not just a big part of the work that I do, because it's been a big part of my own healing or my own process, which is learning to make my own body a safe space or
Yeah.
safer space. You know, there's a whole other tangent I could go down there. But I can definitely resonate with the hypervigilance over what my body's doing. Why am I responding this way? And it's also why I'm very careful what chronic illness communities I engage with,
Yeah.
because sometimes you can just, I personally believe that when you hyperfixate on everything that's wrong with you and all of the symptoms and how bad it is, in my experience, that actually makes it worse. It makes you feel worse physically and
Yeah.
emotionally,
It's
and
a
it
fine
doesn't
line
help
because
you.
there's something in the validation and the peer support and the finding your tribe, which is vital. But there is also something in recognizing the environmental stress, which is a lot of the stuff that we consider to be problematic. Some of it is inherently problematic, but some of it is problematic because of the way that our lives are supposed to be lived and the way we are supposed to act. And so there is a fine, you know, that I can't remember that phrase about before you diagnose yourself with depression, make sure you're not surrounded by assholes. There's an element in this, I think. There's good
I
reason for some
know.
of this stuff. You know, that the hormones are behaviour drivers. You know,
Oh
maybe that
yeah.
agitation is helpful agitation. We tend to want to pathologize and use pejorative language about difference. Doctors love it. We love to point at difference and say, well, there's a syndrome and there's a disorder. But there's another way of looking at it, which is, does it have a function? Is it functioning? And are we listening to what the function might be? And
I was chatting with someone called Sally Garozzo. She has a podcast called the Menopause Mindset Podcast, and that
okay,
this is her thing, talking about how, yes, menopause, absolutely hormonal, but and sometimes it masks a lot of things. So, you know, this is a very layman's term, but during menopause, when your hormones are going awry, well, that means you can't mask anymore. It
yeah,
means you can't continue in codependent people pleasing. You can't continue in a lot of these maladaptive behaviors that maybe were keeping you going, but
yeah,
actually were not supportive to you. You can't take care of everybody else anymore. You can't be the nice woman at work who takes care and does everything. And Sally and a lot of people say how menopause can be a really powerful transition period, because now those coping strategies of all those lovely hormones are taken away. Shit's hit the fan. You've got to get real with yourself about, is this way of living actually helping me and supporting me? So it's
it's.
both
I
and.
agree. I think midlife anyway is a bit of a developmental stage. I think it's one that we don't talk about, but I think it is an important re. Uh, I don't know. You're sort of going back and looking at your stories and narrating them from a slightly different place. What I find interesting is that sort of neurobiological bit, that we know that estrogen in animals drives nurture behaviors, it drives relationship saving behaviors. You know, it really is like having a pair of rose tinted glasses on for it, because not everyone reacts to it in the same way, but for a lot of people, I think it enhances their tolerance of the shit they're putting up with. And then when it comes off, again, we have that tendency to gaslight and pathologize, but often people are just looking at systems they've set themselves up around them, that they're often the one that's doing all the plate spinning, and go, what dickhead set this up? And kind of go, oh, actually, you know, actually, this is part of what.
That was
I know,
me.
yeah, and I just think, you know, it's recognizing again, not gaslighting yourself or letting yourself be gaslit by expectation. There is a real need for some women to go on to HRT because it will help them to manage symptoms, it will give them clarity, it will help them to deal with this stage. It can be really useful, but it has to sit alongside an evaluation of how you're living your life. And trauma often comes to the fore at this point. You know, for a lot of people, it's kind of a perfect storm for that to surface again or demand attention, you know.
Yeah. Yeah. And I have another question now, which is kind of adjacent, because I've seen this come up a lot, and it's because we know that one of the most common side effects or whatever, or things that happens in menopause, is vaginal dryness and vaginal atrophy. And I remember, one of the things that I've learned from various people that vaginal estrogen can be really, really helpful. But I've also heard from people that their doctors refuse them to take vaginal estrogen if they've had breast cancer. What's your take on that?
So my take is a bigger take than my take. The evidence base says that it is very likely to be safe for almost everybody. So for the non-cancer population or non-hormone dependent, so the only cancers that it would have the potential to be problematic in would be the ones that are responsive to hormones. So for many breast cancers, they aren't hormone receptor positive. So about 20% of breast cancers aren't driven or promoted by the presence of hormones. And there are other cancers, gynecological cancers and so on, that have hormone receptors. So for those women that their specific cancer doesn't have any hormone receptors, they can absolutely have it. For the women that do have hormone receptors, in the majority, they can also have it, because the research base shows absorption, especially after the first 2 weeks, when you first start using a product, and these are estrogens that you put inside the vagina or on the vulva. The tissues have become so delicate and thin that in the first 2 weeks, often it does get into your bloodstream and it might increase your levels around the rest of you. But once those tissues have healed, then it's undetectable in the bloodstream of most women. So there's loads of research that shows, but on average, it shows it's indetectable or in very tiny amounts. There's also data of 50 odd thousand people with breast cancer that showed that when they were given these treatments, there was no increase in recurrence rates or death rates. So we've got really big numbers, good data. And we don't have enough data. There's one paper that's just come out that I've not had the chance to read yet, where somebody's done research into what we save when we give women vaginal estrogens. So the decrease in urinary sepsis. So when you get a urine infection in your 60s and 70s that hospitalizes you because it's overwhelming, which is quite common, decreases those, decreases falls, decreases plain urine infections. We benefit not just sexually, we benefit in lots of other ways when we give people vaginal estrogens, and that has to be weighed into any equation when you're talking about it. I'm very ranty about it. I do lots of workshops with women post-cancer on intimacy and on menopause symptoms as part of the voluntary stuff I do. And most of those women are victims of just a very paternalistic, misogynistic view that their sexual pleasure is of no relevance as long as they stay alive. It's kind of, the main priority is no risk whatsoever. But it's not what they've chosen, it's what's been chosen for them by an oncologist. And actually there's relationship breakdown, there's loss of self, there's knickers sticking to you, can't wear jeans, like it's uncomfortable to sit. They're the stories I hear.
I mean, I read a book, it's quite a few years ago. It was called Me and My Menopausal Vagina.
Yeah.
I can't remember the author's name. And, because she had very severe case of vaginal atrophy. And the pain, the actual really excruciating physical pain she went through, and all of the things that, especially male doctors, it doesn't occur to them. No. Even male doctors who work within gynecology sometimes does not occur to them that when you have vaginal atrophy, it causes so many other knock-on real life impact. Like not being able to wear trousers, having to wear skirts the whole time, can't take baths. Just like having to ice your vulva the whole time because you're in so much pain. I mean,
the treatments that exist, the majority of the treatments that exist, the licenses for intravaginal use, and the reason for that was to allow penetration. The main reason that the treatments exist is not female focused specifically, and people aren't aware of that. When you're trained, nobody says, quick, going to tell you about this thing, and it's really influenced by a male driven view of the female body. You just go, well, these are the products that we use, and when we use vaginal estrogens, they go inside the vagina, and that's what they're there for. It's absolutely ridiculous that we don't routinely put estrogen on the clitoris. It shrinks. It's the site of pleasure. Why do you want to have sex if you don't have any experience? But I have to think of that as an extra. It's not the focus of the treatment.
It's so, and it makes me so angry. And like I often talk about, because when we were at the SSM conference, I know that ESSM, European Society of Sexual Medicine. I've heard that it's changed a lot in the past 10 years, but it was, and the symposiums were great. There was some really interesting stuff there. But I just thought it was very, very telling that in the market hall, the hall with all the stalls, I did a quick count. Most of the stalls were to help men get erections.
Yeah.
There were at least 2 penis implant stalls. There were a couple of electrotherapy stalls, which could also work with vulvas as well. But it just was very interesting to see as a reflection, this is where the money is. This is where the interest is of most of the money and research and focus in sexual medicine is still on helping men get boners, which is needed, but it's disproportionate. There was one stall selling lube, shout out to Uber Lube, and there was one stall for the Lich and Sclerosis Society, and there was one very small stall of one woman who had this product of a thing you can put over your vulva to help prevent UTIs during sex. That was it. That was it.
I mean, the vagina is Latin for sheath. And that's what I mean about getting the lens in. I think once you get the lens in and you see the paternalism, you see the we know best, you don't know you. And I'm not saying it should be completely the other direction in the sense that to make an informed decision, you need information. And so the role of a doctor is to say, okay, maybe the information you've had up to this point might be different from the information that I'd like to give you. And this information is based on this evidence. But in an ideal world, it should very much be an exchange of power within the consultation. Often the power is sitting with the clinician who is the gatekeeper. And really, it should be a levelling of knowledge. I've got this knowledge about the condition. You've got this knowledge about you. Let's swap until we've got a decent understanding of each other's position. And then you make a decision on that. But the system and the training, it's slowly shifting. I mean, I'm not a lone voice. There's quite a lot of us now that are sort of talking about this issue one way or another. But it's not curriculum. It's not, it's not a KPI in your appraisal. Are you working in this way yet? And a lot of the areas that are specific to where we marginalise women and we diagnose them, lots of those areas, there's still huge work to do, I think.
Oh God, that's the whole thing. And I love how this is segueing. You've segued us into the second part. And I think with this, I'm probably going to divide this episode into 2 different episodes.
Get long, isn't it?
It's going to get long because there's a lot. And that's the end of part 1, episode 1, part 1. Because when we were talking, we just went on and on and on. There was so much, I guess, information and stuff that we wanted to cover and talk about. So I've decided to split this into 2 parts. So in the next part, we'll be going more into trauma-informed medical care, especially trauma-informed pelvic care, and also talking about neurodivergence, hormonal sensitivity, menopause, the whole shebang. So this will be on YouTube, Spotify, Apple, and anywhere else that I choose to publish this podcast. And as we've said in hopefully both episodes, we're going to be running an online workshop for patients to learn how to better advocate for yourself in a medical setting. So that includes the rights that you have, what to ask for, how to take care of yourself, especially if you know that you dissociate or you have a trauma history, handy phrases, ways to take care of yourself if you know you're dissociating, and potentially we might be creating a printout for you to hand to your medical provider. Again, we know that this is a drop in the ocean. The change should be coming from above. It should be coming from the medical world, but that ain't going to happen tomorrow or by next week. So hopefully this will give you some tools to be able to better advocate for yourself so you have a much more empowered experience and a less shit one. I really hope you join us in the next episode. Yeah, bye for now.